Okay, everybody, we'll go ahead and get started. Thank you guys who are joining virtually and those here in the room who are joining. This is the SWOG Melanoma Open Committee meeting. For those of you here in the room, if you need Wi-Fi access, it's the Hyatt Conference and SWOG 2023 is the password. If you don't mind putting your phones on vibrate or silence, that would also be helpful. And before we get started, I just wanted to acknowledge the terrible conflict that's happening in the Middle East. I don't know why it makes me slightly emotional even just to think about it. I'm not in any way affected by it, but I think so many people are. So I thought maybe we could just take a minute of silence to acknowledge this ground war and air siege that's happening between Israel and Hamas. And you know, a minute of silence is nothing. It's the least we can give just to acknowledge and send, you know, just positive energy over there. So if you guys would just indulge me for this next minute, thank you. That minute seems so long for us here to be in our silence and imagine, you know, what it's like to be over there with everything happening. Well, it's actually a great honor now for me to introduce our keynote speaker, Professor Olivier Micheline from the University of Geneva. I met Professor Micheline in November 2012. I looked up the date. The Switzerland colleagues were very generous in inviting me as a very junior physician to come give some talks on uveal melanoma. I had opened a small trial looking at adjuvant and metastatic disease. And so I was going over there to University of Zurich predominantly, but I think when you were at CHUV, you guys realized I was coming and you said, why don't you come over to Lausanne? It's a train right away. Please join us. And then I ended up at the SAC meeting in Basel that same trip. So I landed in Zurich and then figured out how to take the train over to Lausanne. And it was a little bit out of a movie. I am there. We've never met each other. And you said, I'll pick you up at the train station. And I come out and I don't know what day of the week it is, but you had on what seemed to be like a great leather jacket and jeans and a cute, sporty European car. And I thought, well, this is a little bit out of a movie. This guy's coming to pick me up. So, but then I went over there and saw your beautiful facility at CHUV and then went back to Zurich, and we've stayed in touch really ever since then. You've always been so kind and generous. Olivier gives some of the best talks, honestly. His slides are beautiful. I always marvel at, he puts together slides that are just really, you know, incredible to look at visually. So in Geneva, he's really moved into this position of looking at multi-omics, big data, and how do we put together, you know, data sets to learn something. So he will be giving us this keynote address here on data science for precision oncology.
Good morning, everyone. It's really a pleasure to be here, and I would like to really thank you, Sapna, for this opportunity. We have been discussing quite frequently, and we have realized over the last months and years that indeed there might be some interesting opportunities now that the field is changing rapidly, that we are using more and more large data sets to maybe try and collaborate and bring some of the data together between, for example, national registries. I will show you examples of that, but also maybe SWOG or EORTC or various collaborative groups. So it's really a great pleasure. I'm extremely happy and honored to be here. And I'd like to really start by trying to motivate why we believe data is now fueling at least one part of the research in cancer. And I think there are many factors. You can see here this schematic on the right where this patient has multiple data streams attached to himself. And what has really changed, I think, in the last years or so, is our capacity to generate humongous amounts of data. I'm talking about multi-omics, spatial omics that generate terabytes of data for a single biopsy. We also have now digitalization of the healthcare system, which also provides an unprecedented opportunity to get access to data in a much easier way than we had ever before. And finally, importantly, also advances in the methodology on how we use this data. It's not only big data, it's actually, unfortunately, not often big data, it's rather wide data. So we have a lot of parameters, a lot of information for, at the end of the day, a limited number of patients. Even a trial with 1,000, 2,000 patients is still, from a data science point of view, fairly limited. And the data, the parameter space that we have is absolutely huge. We also have, as you have all seen, evolutions in the language models, which are going to play an important role because these are going to enable using nodes and not only structured data and to be able to gain maybe very important insights. I'd like to start here with a general view of where we stand in oncology. That could be the curve of, IO in renal cell carcinoma or some form of melanoma, where you treat 100% of the patient, but only a fraction will derive benefit. And the whole game here is to be able to magically pinpoint to those patients in orange that I'm showing now, where we have the long-term benefit. Of course, the 80% other patients that were treated did not derive benefit on that line. And knowing who are the patients at high chance of benefit would allow us to design alternative strategies for the rest. And so now the blue patient will get another line of treatment, then the pink patient will get another line of treatment. So if we are able to design, using data science, using everything we have at hand, this type of assignment upfront, I believe we could really bring great innovation to our patients. So the question is, how do we define those predictive biomarkers in the era of digital information? Well, clearly we need to interrogate the tumor. We need to look at the tumor cells, the microenvironment, and clearly data science will be key there. As I just said, we now have incredible amounts of data to mine, and now we need to find what is the cell type, what is the gene expression that is associated with benefit on that orange, blue, and purple therapy. I'd like to take a minute to really position this sort of real world data to clinical data. It's particularly important here at SWOG with the history of fantastic trials that you have been conducting and that you're still conducting nowadays, where we usually have to simplify the question by inputting exclusion and inclusions criteria so that we can minimize the variability of the sample to be able to answer a question in statistical terms. And we have now the machinery to do that in a very performant way. And we can usually have a conclusion here, for example, that the experimental treatment is better than the standard arm. The issue here is that we, of course, bring back this information to the study population, but oftentimes we have to bring this back to the real life. And here we know that there is a discrepancy. I'll just take an example, since this is the melanoma session. We all live with the 067 data, where brain mets patients were not allowed. And it took us quite some time to realize that, yes, ipilimumab and nivolumab have a high activity in the brain. can we change that? Can we use real-world data in order to really complement the information from the clinical trials? So that's the game here. We want to be able to tap into the electronic patient record and maybe get these hints, these evidence as soon as we can to complement clinical trial activity. So data science is really now fueling precision oncology. And I would like to just to show a very short introduction on what we have in our toolbox. You see here 3 big clusters, the unsupervised learning, the supervised learning, where we know the label of the data. We know that this patient will be a responder or not. And then reinforcement learning, which is a new type of machine learning where new data is coming and adding to the data set to further training. And if you take these different groups here, you can sort of map that into oncology activities. For example, the unsupervised could be more closely related to diagnosis. The supervised learning will be associated with prognosis, because you wouldn't have to give survival of the patient as a label. And then treatment could be more closely related to reinforcement learning, as new treatment will actually feed back into this loop of continuous learning. So this is highly schematic. I don't want to push this comparison too far, but it's interesting to see that we're starting to have various tools to answer various questions in oncology. Now, what are the data that we are interested in gathering, and what can we get our hands on? So clearly, clinical data are extremely important. What are the number of line of treatments? What are the exact treatments? What are the doses of each treatment? Were there immune-related adverse event on this IO therapy? All of this information is, of course, extremely important. Patient-reported outcomes are becoming more and more important nowadays. We also have the molecular data that I just mentioned, genomics, proteomics, metabolomics, and then finally images. And I'll spend some time showing what we can now start to extract from images, which is much more than we anticipated. The human eye is, of course, extremely efficient at finding patterns, but the computer can actually complement that in a very interesting way. So I'll show you an example with digital pathology on how the computer can help us assign patient to a high probability of being a responder to PD-1 or not. Now, these data, we want to integrate them. We need a strong reference data set to be able to compare, to know what is normal, what is not, what is deviating from the normal distribution. And then finally bring all that to the molecular tumor board, where we will make an assignment and say, okay, given all this data set, we believe that patient should be a candidate for that intervention. And of course, as we said just a minute ago, for reinforcement learning, this whole process adds a lot of value, and we want to make sure that we're capturing this information on the treatment of that patient and bring this back to the data set so that we keep on bringing more data and fine-tuning the algorithmics. So that's exactly what we are trying to build in Switzerland as we speak, and I'll show you an example on where we are. We started by creating a data ecosystem in the country called the Swiss Personalized Health Network, SPHN, and we responded to that call with the Swiss Personalized Oncology, which is a program aimed at bringing the data together from various hospitals. And you know, that's something that probably is relevant if you know, cooperative groups wants to put data together. When we started this, we wanted to have the 5 university hospitals of Switzerland to pool data together, as well as non-university structures. And when we started that, I get depressed very quickly, because I realized that basically no variable can be compared in any place. It's a different system, which is not the worst. The worst is that, you know, the data are encoded in a different way. So this was actually, you know, the tough start that we had. How do we go from these heterogeneous data sets in the various places to something that you know, we can compare? And the solution we found, which is quite obvious, is to basically ask every center to project their data on a commonly agreed reference data set, a structured form that can, of course, be filled automatically. So now we have those exports done in every centers, and it's not yet completely push button, but close to this. So we can assemble cohorts and bring all the data together so that we can have comparative studies running in real world setting in Switzerland. We can also go back and access the raw data, which is of course super important if we want to get to the next level. So to do this, we do that now on a project base, and we, for example, try to come up with innovative solution. And one of them is this homomorphic encryption method. This is a sort of obscure word, but what this means is that there is a way to bring data from the various centers, or actually to interrogate the various centers without having the data moved and without exposing the data. Everything is completely encrypted. So it's a technical solution, nothing really groundbreaking there. But the beauty here is that since everything is encrypted, the data can be seen as being anonymous, which means that this simplifies the logistic of working with this distributed data environment quite dramatically. And we have done this, and actually a very talented colleague, Jean-Pierre Hubot, has worked ways so that through this encrypted method, we can actually compute Kaplan-Meier curves within the whole country. So you can actually do analytics on data that you basically never see because they stay encrypted in their hometown. And that's, I think, something quite interesting. And if we think about collaborating between the collaborative groups, I mean, this could be also an interesting model. I mean, can we build something like this between EORTC, national registries, and maybe SWOG? So maybe there are opportunities to actually simplify this data exchange by not moving the data, but maybe just being able to access the important metadata in the various groups without exposing them and then keeping complete anonymity. Now, I'd like to show you an example on what we can do with this real world data. And that's an example here where we stumbled on the fact that, unfortunately, in the real world, oftentimes we don't have clean RECIST evaluation of our patients. And we actually have just a report at 3 months after starting the checkpoints. And this report is a free text. But as we all know, now our capacity to understand free text has gone through huge revolutions. So what we have built here is probably not a baby ChatGPT, but it's less than that. I mean, it's a very simplified network. You can see we have 42,000 parameters. It's really nothing compared to 170 billions for ChatGPT. But it's really trained to only do one thing. It's to qualify a patient based on this report into a responder or a non-responder. So that's this only thing that this mini ChatGPT can do. But as you will see, it performs reasonably well. So we actually started with about 6,000 curated PET-CT and CT reports. And we divide that into a training set and a validation set. So the training set is about 3,000, and it's the accuracy of the predictor of this neural network, this mini ChatGPT on the training set is the blue curve that you see on the right. And you can appreciate that we reach 90% accuracy. So the number of times we call the patient a responder or non-responder, and this is true. And then you can start to see overfitting. The curves goes above 90, which probably shows that then we are fitting the parameters to that data set, but this has no universal component. So on the validation set, which has not been used for training, you see that we saturate at 90% accuracy, which is a fairly good number. It's not perfect, but it really shows that we are able to tell whether a patient is responding yes or no based on this natural language processing. By the way, if we give that same report to several clinicians, which we did, we also have 90% agreement. So it means that probably that's as far as we will be able to go. And being in melanoma, I ask the teams to actually take out all the melanoma patient out of this analysis to have a sort of a third level of validation, which is to really use not only data that were not used for the training, but a completely different disease. So the training was not including melanomas, and we then use melanomas as a second level of testing. And you can see that we maintain 90% accuracy, which is good sign because these are not the same radiologists analyzing melanoma. And as we all know, the pattern of metastatization of melanoma is very, diverse. It can go basically anywhere and probably less than what we see in other cancer types. So this was actually a good test to show that perhaps this really has a potential to be useful. And you can see that if you use such an algorithm, you call a PFS curve very similar to what you would do with the human validation. So this was actually quite good news to us. And you can actually now start to analyze hundreds of thousands of patients automatically, which of course brings a lot of information. So that's exactly what we have done through this network of data. So on the left side, we have our very well-known 067 clinical trial. You have OS on the upper part and PFS on the lower curve. And on the right, you see what we obtain from a single center using this algorithmic on real-world data. And you can see that, for example, if you look at the upper panel, the OS asymptotic values, we have 52% on EP-Nivo, 38 on Nivo instead of 44, and then 30 instead of 26 for EP. Reasonable numbers, the same behavior. So you can see that, this is a very small cohort compared to 067, but it does show that we are actually seeing data that are meaningful and they can reproduce what we know in melanoma. We pushed this a bit further and used a new technique in machine learning called process mining, which analyzes the various steps of the treatment of a patient. So what you see, the upper panel here is the first line treatment. The second line is the second line of the panel, and the third. And what you can see is that there are thick lines and small lines, and the thick lines are IO patients. So it's either EP-Nivo or PD-1 single agent. We really have a strong focus in using IO in the first line, as we know very well. This was actually even before the DreamSeq and SECOMBIT data. And this actually is a way to assemble a cohort that answers the question. So here, what we wanted is to recapitulate the DreamSeq trial. So basically, we took all the boxes that actually correspond to the patient population of the SECOMBIT, or actually of the DreamSeq trial. And so basically you can drag and drop those boxes into a cohort 1 or cohort 2 that you see on top. And that's what we found. You see here, so here we look at PFS, we have also OS data. But for PFS, that you see that we have a very similar behavior. We see that the progression is preserved on the TKI treatment arm first, but then there is this crossing, and then as we all know, most of the TKI patient will progress, where you have those long-term benefits on IO. So basically, in the data set of a center, you have data that is backing DreamSeq. It's actually, of course, the opposite. We believe in DreamSeq much more than we do on this small data set, but nevertheless, it's very, very interesting to see that the data in the real world match what we know from a trial. So that really asks the question, if these data sets are, meaning something in terms of the behavior of melanoma patient, can we do various trials in that data set, actually trials that will probably never exist because they are not ethical or because they cannot be logistically performed? And the answer is yes. We are now analyzing this data set through various cuts. And so we're basically trying to produce virtual trials for questions that we have. And we believe this could be a very nice way to generate hypotheses and to probably launch new trial. And that's also another interesting area for collaboration with SWOG. If we can pull together, ERTC, SWOG, national registries all together, we would have a huge data set, and this could be hypothesis generating for trial design. That's also another area that we probably should contemplate. In our case, we also use that data set to look at co-medication. So that's the medication that you're taking when you start PD-1 based therapies. And you can see that proton pump inhibitors came out as being perhaps an important factor. Patients taking PPIs are actually showing a worse behavior than those that do not take PPI. So this was an intriguing finding, and then we teamed up with BMS to try and confirm this finding. And you can see that we looked at 067 on the left and 069 on the right. And probably the story is quite complicated. You can see that on 069, we do see this phenomenon. We see that patients on PPI are actually doing worse than those without PPIs, and we don't see that pattern on 067. So clearly, more to understand whether perhaps the patient population is not the same and the microbiome is not the same. So something that we have to analyze. But nevertheless, interesting to see that there can be flux of information from the real-world data to clinical trials back and forth. So now I'd like to go to the image analysis and show you what we're trying to build. So we wanted to be able to have biomarkers that can be used for all of our patients, and we don't have multi-omics data for most of the patient, but we do have pathology. There is just no patients that will not have an H&E slide. So now the question is, can we build an algorithm that will capitalize on the information that you have on an H&E slide to predict outcome? And what we have worked is the pipeline that you see on the right. So we first are able to delineate automatically the tumor region. So the algorithmic can recognize where is the tumor. Then we can segment the cell, find where the nuclei are, and then assign a cell type to this nuclei. You can say, okay, that nuclei must be a lymphocyte, that must be a dendritic cell, that must be a cancer cell. Then from this pattern of immune infiltrate or the relationship between these various cells, we can build a model. And I'll show you where we stand now with the latest version of our model. You could actually, if you have enough data, take directly the slides and then ask a deep learning classifier to go directly to a prediction of whether or not that tumor image will be that of a responder, yes or no. However, that would put you in a very dangerous spot, because if the H&E is not done the same way everywhere, that could definitely bias your algorithmic, whereas going through this intermediate step of finding which cell type this is probably much safer. That's the reason why we went through this. As always in machine learning and artificial intelligence, what makes the biggest difference is the training set. You might know that now we have cars that are very close to be self-driving, and one of the reasons why this has moved so nicely in the recent years is because there is the capacity to generate synthetic data. So, for example, there are ways to train the algorithm, the algorithm with, a crossing where the light is green, there is someone on the left, there is rain, so on and so forth. We can generate all these type of possibilities so that the algorithmics become more and more robust. It's exactly the same here. So what we wanted is to have a large data set to train a classifier that can recognize lymphocytes. And what we have used for that is immunofluorescence. So we used a CD3 marker to make sure this is a lymphocyte. And then we worked out a technique in the lab so that we can co-register that on the same slide with the H&E. And that's the images that you see on the lower left panel. You can see the immunofluorescence with the green lymphocyte being identified. And on the left, you have the corresponding H&E. So now the algorithm can learn that, yes, this is an H&E, this is a lymphocyte based on the immunofluorescence. And so we can have millions of cells of training. So that really brings incredible power, because with just a few slides, we have millions of data points to train our algorithm on. And you can see that with this, we were able to really reach a very high predictive value for the algorithm, around 80, 90%, 95%, depending on the cell type. So you can see now this algorithm at work. You can see that how it's detecting some of the lymphocytes on the right panel here. And we, of course, do that in very close collaboration with our pathologists. But we believe this could be really an interesting aspect, because, again, it's commodity data. Everyone has those slides, and they can be digitalized so they can travel easily. So how does it work? First, we looked at the typical features that we look at to predict outcome. And the first one is the density of lymphocyte, the number of lymphocyte compared to the total number of cell, or the number of lymphocyte per tumor area. And this has some level of stratification power, but you see it's not reaching statistical significance per se at this level. So we went on to go to more. So that's what a pathologist or human eye would do on a very limited slide region. So of course that we can do in a nanosecond on the whole slide, or on 1,000 slides as well. But we can actually go into more advanced metrics, and this one here is actually very intuitive. That's the little drawing that you see in the middle, where you have a lymphocyte, and you look at the density of non-lymphocytes around that lymphocyte. That means how infiltrative is that lymphocyte, since it's alone without having too many of other lymphocytes around itself. And you can see that that parameter, that feature, is actually bringing a much more powerful classification. So that's a measure of T-cell infiltrativity that you can actually not compute by eye. It's actually not possible to get those statistics with the human brain. And that's something that actually complements what we can come up with from the pathology. So that's one example, that's one feature, but we can compute thousands of them, thousands of different statistics on how the immune cell, the dendritic cells, the CAFs, the myeloid compartment, so on and so forth, are interacting with the tumor. And if you put all of these together and try to select those features that are mostly associated with outcome, but actually are different among them, you can actually build a predictor that starts to become interesting. We have now 0.78 AUC, so it starts to become quite interesting. And you can see that on the right side, the way we separate survival of patients that are undergoing PD-1 based therapy is interesting. What is interesting is we get, of course, good outcome for the patient that are positive, but the negative predictive value is also very interesting, because it means that that could perhaps tell us you're going to lose time treating this patient with a PD-1 based therapy, and maybe that's a candidate for something else. Should he go for TILs? Should he go for other therapeutic opportunities? Just a first step towards an external validation. We can see that we hold the same sort of stratification on an orthogonal data set with an AUC of 0.67. And so that's an example where it would be fantastic to be able to run this algorithm on a data set from SWOG or from EORTC to validate whether this holds also on a larger external data set that has not been used for training. We can go one step further and use graph methods to understand the environment of each cell. This graph is made by doing a triangulation of the different cells and then looking at cells that are at borders, where you have the immune component on the one side and then the tumor on the other, and actually taking into account this border that you see in orange on the lower panel. That border actually contains a lot of information. We know that since the work of Tony Ribas quite some time ago. But this actually comes out of this analysis as well. The border is really a critical region to look at, and that's something that brings most of the information. And you can see that our AUCs are actually improved when we specifically focus on the border. So I'd like to just go very quickly on the exploitation of PET images. So basically, it's the same that we have seen. It's just different image types. But we can use AI to basically contour the tumors more or less automatically. Some can be done now mostly automatically. Some still require human validation. And those contours that are really the contour of the tumor can be processed through these same techniques of AI and associated with outcomes. So we can extract a lot of features on the tumor signals and then try to correlate that with outcome. We have done that in the same data set as previously. I mean, so it's just a part of the data set here, but you can see that we see a texture in the PET-CT that is associated with response, yes or no. And to cut a long story short, the more heterogeneous the PET-CT signal is, the worse the outcome. Highly intuitive, but nevertheless quite useful if we could bring and validate a digital biomarker of that sort for the clinic. So just to conclude, we are now bringing this to the patients in a molecular tumor board. So the idea is that when a patient is addressed to the molecular tumor board, we bring a team with, of course, medical oncologists, dermatologists, pathologists, but also data scientists. And those data scientists, they are here to help us try to maximize the information in the data sets that we are having. Those patients are all patients who have failed standard of care. So we're using those developments to really guide therapy in patients where we would not know how to go to the next line without the data. This has come with a great activity. We have now more than 3,500 patients that have been processed in those tumor boards. And we have quite a bit of data at hand there. We have digital pathology, we have sequencing for most of these. And you can see that we have a normal representation with all tumor type, melanoma, of course, being one of the types. And now we're moving to the next level with a fresh interrogation of the tumor prior to this whole process. And that's going to fuel two streams, a targeted omics that you see in the middle, where we will have digital pathology, but a lot of other technologies, and also exploratory omics, where we will do single-cell RNA-seq, spatial transcriptomics, and so on and so forth. And all of this information goes back to the tumor board for an educated decision on how we should treat the patient. And of course, the patient evolution is being brought back to the program as well. So now we will have interesting data there, which again could generate hypotheses. And as we have digital pathology there, we could then use digital pathology to go and look at other databases, whether that hypothesis is observed in other data sets, yes or no. So that's another example where we could see interactions. So just to conclude, that's the last slide. How could we interact with SWOG? So clearly, data science requires a lot of amount of data. Data can be shared, but conversely, the algorithm can be shared. And I'm not trying to show this here. So if through local mining, as I have shown you, you find an interesting AI model that can predict the benefit of a patient for a given setting, then rather than exchanging data, what you can do is actually travel the algorithm. And the algorithm is just parameters of a neural network. So this is nothing in terms of the security issues and the regulatory affairs and all that. So we could then use this in a databases like SWOG or ERTC and so on and so forth. And then of course, optimize the algorithm to then be able to have a much more robust algorithm to treat patients, or to bring into molecular tumor boards, for example, or to run trials, or to analyze retrospectively some trials. And you can imagine that those algorithms could actually travel the world and get improvements as they go through the various centers. And I think this could sound a little bit like a dream, but I think it's actually technically and on a regulatory aspect not impossible to do, and actually becoming feasible as we speak. So maybe it's the time to think about ways where we could maybe try to do that between Europe and the US and so on and so forth. And of course, that could be done on clinical images, PET-CTs, or digital pathology, or actually even clinical data, as I showed at the beginning. So with this, I'll stop, and thank you very much for your attention.
If anybody has any questions here in the room, please use the microphone so that our Zoom colleagues can hear. We have someone coming up here. Josh.
Great presentation, really interesting. I had two questions. One is that in terms of the radiomics, there was kind of you had alluded to a precursor to that, where you use natural language processing to look at the radiology reports themselves. And so my curiosity there has to do with what has the greater value? Is it having that interpretive radiologist description helpful? There's often some nuance there, some additional information perhaps that you find there. Would it have been better if that data had been more structured, meaning it was more ordinal data, or is it better to use natural language processing, or is it better to do radiomics? So that's my first question. My second has to do with the FDA has a Right to Try Act where individuals who are in dire situations can access investigational drugs, and the challenge there could be perceived as they may not go on clinical trials because they're accessing them outside of the clinical trials mechanism. I'm wondering that if by using this type of analysis, could we glean information not only to come up with clinical trials that based upon the data of those individuals that tried, but maybe even forego clinical trials. I know this sounds a little outlandish, but forego clinical trials because there's just so much data there that the clinical trial itself, a randomized trial, would be redundant.
Well, thanks so much. These are extremely important questions. I think, we definitely need clinical trials. That's for sure, but to validate things. But I agree with you that, now we are living in a landscape where we have so much information that it's actually, becoming difficult to even design a clinical trial. And I think that's what you alluded to. I mean, if we have this process in place where we analyze this patient with that depth, for example, through molecular tumor boards, maybe we can actually use the data to the best of what we know at this moment to assign patient to treatment, but then we can look at the data retrospectively and then start to cluster patient and look at what are the patients that do derive benefit. What do they have in common? I mean, is it the spatial information? Is that the clinical history? Is that the gene expression profile? And that or actually combination of the above. I think that would be invaluable because then it will pinpoint to those patients that really stand out and have a high benefit, and then you can take the same network to run a prospective trial where because those tumor boards, they do this analytics anyway, so it's present everywhere, it's normed, and you know what you're measuring, and so if you were able to define this patient population retrospectively, then you can use the same engine to prospectively validate those patients and those findings. And so that might be a way to go from real world to clinical trials and then back to real world. And I think in the future this could really be interesting, and that's a way to solve the N=1 problem, which is really now becoming an issue, because how do you define a patient population? We are using now more clinical variables to do that, but as we are moving towards multi-omics, we know so much about the tumor. So should we actually, group all these patients into a big box, or should we go in finer detail? What is the cutoff? What is the granularity? And I think one way to answer that question is actually to measure this, cluster the patient, find those that are associated with benefit, and then use the same network to prospectively run a small clinical trial with, these very, important a metric being engineered in the trial, where probably a small phase 2 would be highly conclusive because you really narrowed those patients with high benefits. So it's a very, very important question. And to your first point of what's the best, using NLP on the report or radiomics, as always. So we don't have the answer there, but as always, probably the more data inputs that are orthogonal you have, the better. I mean, machine learning and AI is very good at being able to identify which data should be used at which part of the neural network. And so, if you have access to both, I'm betting that, you're going to get an increase if you're able to do the radiomics on the one side, and then the analysis of the record from the radiologist on the other. Needs to be validated, and that's again something where the numbers we could get if we are able to put those databases together would allow us to answer such a question. At the moment, it will probably require way too many patients compared to what we have.
Olivier, I love your talks always. Please, Mike, if you have a question. I had a question for you along this line of natural language processing. I was relieved to see that the physician-assessed response non-response was the same. Essentially, even a physician is reading this report and not getting it right 100% of the time because it is not always clear. And so we feed that information into this, AI that will then tell us basically what human beings are interpreting. It makes me wonder if we can do away with things such as the cost of central radiology review on a clinical trial, and have pilots. One of our studies that might have imaging assessments, maybe even pilot this idea of what was it called, what was the percentage tumor, and would AI have called it as such as well? So that's a really interesting idea, I think, that natural language processing might be able to centralize some of this. Is that really where you guys are trying to do it? Or it's to pull real world data sets and just
at the moment it's really to exploit real world data, but I really like this idea. I think it would be very efficient. I mean, you could imagine in some trials to test the water and having the usual central review, and then NLPs running in each centers, and then see how bad or how good this is. We tried that recently because this NLPs we developed it at the Lausanne hospital, and then we are now trying it in Geneva, and the performance is more or less the same. So transportability here has been quite good. And if you think about the US, the language homogeneity is very good, which is a huge factor there. So we could imagine that this could be a very nice way for the future, and I really like the idea.
So I have a couple. Well, first of all, just a comment in terms of portability of algorithms, 100% there. If you want to link up with SWOG, it's actually very simple. You send me an email, I give the algorithm to one of my postdocs, and then we just run it for you, assuming the trial has already read out. So that's actually not terribly difficult. The bigger question that I have, though, is throughout all of this, it seems to me data is king. And you just need tons of data. I mean, for the NLP things, you showed 6,000, but for most NLP problems, that's actually a very small sample size. And so how do you envision really training all of these different models that you have? I mean, certainly you've done a great job with what's there, but for instance, with Sapna's question, if you really want to do away with centralized pathology review, you're going to need to sort of train it on for that specific task within the context of desmoplastic melanoma or something else. I mean, I'm sure you can, you can take your base algorithm and then try and adapt it somehow. But do you have any thoughts about this?
It's a $1 million question, and it's a great one. I think it's a very difficult one because I think we cannot preempt and know in advance what will be the size that will be required for a specific question, because it depends a lot on the sort of the signal to noise ratio. What is the information contained into those patients? If you look at the digital pathology analysis that we have done, it's a dismally small number of patients. We're talking about like 60 or 80 patients at max, which is extremely small. And if you look at the literature, a lot of the digital biomarkers that are coming out are actually based on very small numbers. Now for NLP, we went to 6,000, not for the fun of it. We actually realized that, we needed big numbers. But here, I would think that, what we basically took is, and then we built from scratch, a natural language processing using a neural net. But now with ChatGPT, you could probably do a lot of saving of the training, because basically that thing understands language like nothing else on earth. And so that could be a first step. And then if you train a GPT on a few patients, maybe you don't need 6,000 to actually converge. So I think your question is extremely relevant. I don't think we have a very clear-cut answer at the moment on what would be the sizes needed.
Okay, thank you. It's really interesting.
Thank you.
The other thing it makes me think about is, Megan, it makes me think of your DART trial. So there was a very successful SWOG trial, dual antibody therapy for rare tumors, basically Ipi-Nivo for any tumor that has no indication. You could have theoretically, so a lot of sarcomas and many other tumor types, and they found a lovely signal in angiosarcoma. And, but it makes me wonder if there isn't some omics level data in all those rare tumors where the neural network might actually be connected to say, this is the biomarker across any tumor that looked like it was a signal, that your individual cohorts may be too small to pick out because whatever cancer only had 10 or 12 patients, but from a neural network level, it might be.
Yeah, I love that. And that's very, very interesting to hear. Actually, in our trial where we do this multi-omics, we have 4 cohorts. We have melanoma, lung, breast, and GI. And the goal of our research program is exactly this, is to find patterns associated with response between or within the same disease type. And I'm convinced, that there might be, or there must be patterns that are associated with this. And is it the fact that you have lymphocytes that are highly infiltrative in the tumor? Is it a property of the border? I mean, of course, that's not going to work for everything, but that there are commonalities on the way an immune system that will respond to checkpoint is distributed within the tumor is highly likely. And I think it's exactly where we should go, because then if you scan those patients with digital pathology algorithm, boom, even if it's a rare tumor, you'll know about 80% chance of response with ipi/nivo and LAG-3 or whatever, in a few years. And then that might be revolutionary if we can achieve that.
Thanks. To get to what you were speaking about, projecting data onto some sort of data sheet that's uniform across sites. So saying going beyond SWOG, trying to get to multi-institutional and outside of SWOG data necessarily. My question is, do you think it's enough to run validation? How much of that has to be put in on a human input site? How frequently do you have to review that data to ensure you don't have a garbage in, garbage out phenomenon to really assess the validity and reliability of each site and what they're inputting into larger data sets?
Very important question. Thanks for asking this. I think it's a little bit of an in-between response. I think usually when you start out, you have a certain level of success. We really quickly reach 80, 90, 95%. And then based on this, what we usually do is we look at the outliers where we didn't go well, and then we feed that back into the algorithmic and look at whether we can do a few cycles of optimization, and then we sort of plateau. And then what is very important with those algorithms, for example, the NLP, I showed you here 2 classes. It's responders, non-responders. But actually our next generation classifier has 3 classes: responder, non-responders, I don't know. And that's super important because we realize that the I don't know is actually fairly accurate, and that matches where we are wrong. And so that might be a way where you are able to really pinpoint to the files that you should look at, and maybe there on a 1,000 patient trial you only look at 17 patients, and actually at the end of the day maybe that process might even be better than just doing full force the whole thing. So it's still work in progress, but I believe this could be really transformative because you could use the data management resources where it matters the most, and then all the simple case basically the AI would go through, and of course you would do QC and take randomly 100 patients and then check, oh yes, this is correct, yes or no.
Lovely. We do have a question from our online audience here. The question from Ankit Mangla, he's one of our investigators actually through ECOG, but trying very hard to become a SWOG member. Does AI have the capability to assess images in 3-dimension versus 2-dimension?
No, absolutely. There are attempts to do that. I just saw, we're not doing that ourselves, but I just saw a fantastic talk of someone actually just taking consecutive slides in pathology and then, looking at the 3D information on top. And there is a gain, that you can prove, but it's very small. And it costs a fortune because, if you do multi-omics on one slide and then you need, 50 slides to get the 3D version, of course, it's 50 times the cost. So I think I'm sure there is a space for that. I'm sure this will be useful in the future. At the moment, the first results do not seem to show that there is a huge benefit, and of course the costs are exploding. Now, of course, if you look at the images from PET CTs or CTs or MRI, it's actually a 3D interpretation from the beginning. So the classifiers that we're building, they look at the whole image and the whole volume of the tumor.
Nice. Well, once again, I want to thank you for coming all this way from Geneva. I know it's a big trip, but we really thoroughly enjoyed this. I think there's a future for SWOG and you guys to work together with us.
I would love to.
Yeah,
Thanks so much.
Thank you. We have a little token of appreciation for you from our committee here, a little bit of SWOG swag here for you. And let's give Professor Michelin a round of applause. Okay, for those of you following along in the meeting booklet, I take full responsibility. It is not accurate. This is not the meeting agenda for this year. Somehow it's an old one got pushed forward. It's my fault. So we are going to, over the course of the next hour, go over study updates for 3 of the active studies in SWOG. And then we'll go over some updates for our closed studies. We'll hear from our ECOG liaison, our patient advocacy, and then we will wrap up. So the first study, and I am going to ask for all of the speakers coming up, we heard about this morning in both Board of Governors and committee chair meeting. We actually really should be disclosing any conflict of interest at the beginning. I don't know if it was necessary yesterday in working group, but certainly here. So as you come up, just to give your study update, if you can just, in a quick sentence, mention if you have any conflicts with maybe the work that you're presenting that's being funded. There's no problem with conflict. It's the cover-up. Remember, it's not the crime, it's the cover-up. So first, we will start off with S2000, which is Zainab. Zainab, I'm sorry, I might have emailed the inverse order, but your study comes first numerically. So.
Hey, thank you. In terms of any conflict, so for this study, S2000, we do have Pfizer providing the encorafenib and binimetinib, and I've previously been on an advisory board for Pfizer, but besides that, no other conflicts to disclose. So just an update for S2000. So this is our study looking at encobini and nivolumab versus ipi/nivo in patients with BRAF mutant melanoma brain metastasis. Just a reminder of the study schema. So looking at the triplet combination versus the standard dosing of ipi/nivo. And we are stratifying the patients on whether or not they got neoadjuvant or adjuvant treatment more or less than 6 months prior to start of enrollment. And the objectives, as a reminder, our primary objective is comparing progression-free survival in global PFS, so either intra or extracranial. And then secondary objectives include overall survival, response rates, toxicity profile, and some radiographic response criteria, looking at different ways of assessing brain metastasis.
It's a place where we could use AI and some of that blinded radiology review.
That's right. So we do have actually, we are banking the images, the MRI images from all the sites, the serial images for the patients. So reminder of the eligibility criteria: patients have to have BRAF V600 mutation, now symptomatic brain metastasis, which we'll get to in a second. Steroids permitted up to 8 milligrams of dexamethasone. Prior local regional treatment, radiation or surgery is permitted as long as there's one measurable, at least 0.5 centimeter progressing brain met. And we do also allow leptomeningeal disease as well, and they don't have to have any extracranial disease. And we allow prior neoadjuvant or adjuvant PD-1, CTLA-4, BRAF MEK inhibitor, but patients must be in the first line of their metastatic treatment. So just some updates with our enrollment. So our goal, as we had amended the study earlier this year to specifically focus on those with symptomatic brain mets, whereas previously we had asymptomatic as well, is for 28 patients with symptomatic disease, which requires 24 eligible patients. That gives us 80% power to detect a hazard ratio of 0.41 between the study arms of the triplet versus ipi/nivo. So thus far, we've had 29 patients enrolled. So that does include the previously enrolled asymptomatic patients as well, prior to the study amendment. So here, as for some of you not familiar, since the spring meeting, we did do a very comprehensive evaluation of the symptomatic brain met patients enrolled to date, especially as a result of a revision of the data from the TriCatel study. So that was, some of you may be familiar, a single-arm phase 2 study that was looking at Vemcobi and atezolizumab in melanoma brain mets, and that included a symptomatic cohort. And there have been some, commentaries that the symptomatic patients were defined as such because of things not relating to brain mets, such as pain from thoracic or pelvic mets or elevated LDH. So because of that feedback, this data from that study was reanalyzed and then published again earlier this year to be more specific with how symptomatic disease was defined. So we just wanted to make sure that we weren't going to have the same problem. So we have looked at all the enrolled patients thus far to make sure they do meet the criteria of having either corticosteroids at baseline, again, up to 8 milligrams of dex is allowed, or that the symptoms they had were actually neurologic symptoms from the brain mets and not other types of symptoms. So kind of going through all the patients enrolled, and I reached out as a result to some of the investigators and definitely appreciate the responses. We did find a handful that were miscategorized in either direction. So for example, we had a patient that's categorized as symptomatic who had a painful right axillary lymphadenopathy, which while a symptom is not a neurologic symptom, presumably not from the brain mets, versus we had another patient who was actually receiving like 4 milligrams of dexamethasone at time of enrollment, where the site had put asymptomatic, because I think the thought was, well, if the neurosymptoms improve with the steroids, therefore the patient is asymptomatic. But that, again, our definition is baseline steroids or neurologic symptoms for definition of brain metastasis. So, I'm sorry, for definition of asymptomatic disease. So basically, just as a quick update, we do have 20 patients, kind of after going through all the 29 enrolled so far, that I believe do fit this definition of symptomatic brain mets. And we can see here it's about half and half randomized to the 2 study arms. Half of those 20 patients were on dexamethasone at time of enrollment. I was looking back at the TriCatel data, and I think for those 26 they had in their symptomatic cohort, about 40% had been on steroids. So I think this is about equivalent, so 50% on steroids. We can see half and half on each arm. The dex dose could be, again, as high as 8 milligrams. And then the neurologic symptoms that I think, do fit the definition of, potentially being from the brain metastasis include headache, confusion, dizziness, falls, loss of fine motor skills, loss of cognitive impairment, speech difficulties, etc. So in summary, we have 20 of the 28 patients. So definitely appreciate, the sites continuing to look for patients. And again, if you haven't opened this study, I would make a plug to consider opening it. Most of the sites have enrolled only 1 or 2 patients. But again, in a small study with just 28 patients, even 1 patient is just invaluable in helping us complete the study. So do consider opening it. And as always, feel free to contact me for any patient where there's any question about eligibility. I know these patients, their cases can be more complicated. So yeah, if there's questions on eligibility, symptoms, etc., just feel free to reach out. And I'm hoping by next year, we will have completed this trial.
Zainab, thank you. I have a few questions. We know the use of dexamethasone for brain mets, but if some sites are for some reason using prednisone or something else, is that also allowed as symptomatic? It's not just dexamethasone, right?
Correct.
Okay.
That's a good point. In the protocol, we have it as just corticosteroids,
Okay.
so up to 8 milligrams dexamethasone or the equivalent. So correct, it doesn't have to be specifically dexamethasone.
Okay. And then what about nausea? Is that a neurologic symptom or not for the purposes of this?
So I think that we'd evaluate on a case by case basis. That I didn't see that come up in our
Good.
in these patients. So I think with Tricotel, nausea was counted as a symptomatic brain symptom in a patient who had a cerebellar metastasis. And then, the investigators thought, well, the nausea could be from that cerebellar met, and they didn't have a good alternative explanation. So I think that one we could assess if it comes up.
Yeah.
So.
And then for the patients that were coded, one way and into one category and one in the other, are those corrected in this assessment of 20 patients? That's with the patients reassigned or not yet in the database?
So they haven't been reassigned in the database. So I think currently the database reflects 21 symptomatic, the weights, but I think once we fix
Move
these
those
handful
over.
of patients, it'll be 20. So about the same.
Okay. And I see Jim is on here virtually. So I assume Jim is helping to move this with the protocol study coordinators. Yeah.
Yes.
Okay. Excellent. Any other questions for Zainab? Anything else? Okay. Thank you. All right. Next, we'll have S 2015, Josh Mammon. This is a non-drug trial. So I assume there would be no need to make a conflict of interest statement, but maybe for posterity, go ahead and say something.
Yes, I can confirm there's no conflict of interest with this trial.
Okay. Thanks.
All right. Thank you again for the opportunity to talk about S 2015. So this is the melanoma margins trial. So the objective of this trial is to determine whether there's a difference in, or to evaluate a no difference in disease-free survival between a 1 centimeter and a 2 centimeter margin in stage 2 melanomas. These are the secondary endpoints that we also look at, and we'll talk a little bit more because there are some PROs in here that will hopefully soon be relevant for this trial. So this is the schema. This is individuals who are 18 years old, stage 2. There are some stratification criteria that, as you can see here. And again, very simple randomization, 1-to-1 of 1 centimeter versus 2 centimeters. And then their follow-ups afterwards looking for evaluating for disease-free survival. So this is the current status. It activated about a year and a half ago. There are now 97 sites open, 365 subjects when I last evaluated at the beginning of this month. Our current SWOG accrual goal, which again we'll talk about in a moment, is 880. Hopefully that will change in the not too distant future. We're doing quite well. Last month, 40 subjects accrued, which is really quite remarkable. So thank you for the tremendous effort by everyone. These are the sites with the top accrual currently: Spectrum Health in West Michigan, Moffitt, KU, Ohio State, University of Utah, Northwestern, and Rutgers. And then a particular thanks to our the other cooperative groups, particularly ECOG, who has 69, but also Alliance and Energy Oncology. So it's really a tremendous effort by everyone in terms of accrual. So these are kind of the submitted and pending. There is a pretty robust PRO component of this trial internationally that is not active in the United States. We are hopeful that will be active in the near future. It has been submitted to CTEP for evaluation, I would say just about a month ago. So we're hoping to hear a positive response. That already is in the protocol of those of you who have activated the trial. It's not in the SWOG amendment, obviously. But once it becomes active, we'll make sure that there's robust information that's sent out. It's very straightforward quality of life components. Additionally, with our tremendous accrual, it's apparent to me that sometime next year, we would reach the 880 target. So we are in the process of submitting to CTEP and increasing the complement number to 1,200, which we're hoping also for a favorable response. So stay tuned for that. Obviously, no immediate consequence for any of the sites, but we're trying to avoid reaching that upper barrier next year. And then finally, there is we've been working with Dr. Polsky at NYU on a translational medicine proposal, and this is a ctDNA component to the study. It's really for surveillance with liquid biopsies, both evaluated prior to the wide local excision and then serially following individuals. He has some good data, kind of in a preliminary fashion. We may have seen some of his data at ASCO this year. So we're hoping to be able to further validate that information and demonstrate that perhaps liquid biopsies may be a different modality to follow these patients closely and help to stratify them. So finally, acknowledgements, of course, from the entire SWOG team who have worked really hard to make this kind of relatively unusual trial, since it's an international collaboration functional. The MASS team based in Australia, CTEP, and of course, most importantly, are the patients who have agreed to participate in this trial, making this possible. With that, happy to answer questions.
Do you have any sway over, I mean, this is data, so it kind of goes to what we were talking about. The issue with SWOG opening this in the US was SWOG has its own electronic database, but MASC obviously is the sponsor of this trial. They have a database, and what we couldn't seem to smooth out was having data in the SWOG database communicate to MASC. And so the delay for you really in opening this trial was getting the agreements that SWOG investigators would input directly into the MASC database. So I guess the question is, what is your ability to mine any of that data or to do anything like, you know, AI extraction or any sort of multi-omics extraction on that database?
Well, certainly MASC has been helpful as we were devising the translational component for this trial, which is really only for SWOG sites or US sites. That data has to be, there has to be able to discriminate data that is SWOG data, our cooperative group data, versus the general MASS database. So there is an ability to be able to differentiate that one data set or group of data from another. So there is that ability to look at just SWOG data separately from the overlying MASS data.
Mm-hmm.
When analysis is done for a quality monitoring standpoint, all the data is aggregated together, and certainly, you know, I obviously get the DSMB reports, and we review any potential violations of protocol, regardless of whether or not it's our sites or other sites. But there is an ability, if we want to look at our data separately, to be able to tell.
Mm-hmm.
Thanks for the update, Josh. The quality of life assessments are a big lift for patients, investigators, data managers. Do we know from MASC what percentage of the quality of life assessments they need from SWOG to actually meet that endpoint? Do we need to do the quality of life assessments through SWOG? Will they make it without us? And if so, if not, then what percentage of the quality of life assessments are they expecting us to input?
Sure. No, that's a great question. And you, of course, have a tremendous experience with this already because your site enrolled on this trial prior to it being a cooperative group trial. It is a big lift. I think one of the greatest values of this trial is the quality of life component, meaning that the morbidity associated from a quality of life standpoint of a 2 centimeter margin versus a 1 centimeter margin. Those of you, all those of us who treat melanoma, obviously all understand that. I do not think that without our participation in this PRO component, that there would be enough data available to make that component of the trial valuable. So I think that's a really critical reason why we have to, or we should participate in the PRO component. And I do think the PRO component, again, is just incredibly valuable. There is already a built-in expectation that not all individuals would participate. The number that I've seen batted around is that they need 600 individuals to participate total out of the trial in order to and have all of the data in order to be able to make any conclusions from the PRO component. But with our robust accrual in the United States, I think that our participation would be essential. The exact percentage that would be we would be able to tolerate not participating, I don't have that number offhand, but I could look into that. And certainly I would appreciate tips from your experiences as well on how to do this well, because I know your site has that experience.
All right.
Great.
Thanks, Josh.
Thank you.
Okay, next up is Katie Size giving an update on the Alliance trial, except Katie Tsai was called for jury duty this week. So she is not joining us here in person, but she did provide some slides that I'll go over here quickly. This is the Alliance Trial 091903. Katie serves as our SWOG champion for this trial, mucosal melanoma in the cooperative groups. So kudos to Alex Shustari for getting this going. This study, as you guys might remember, has two different groups of patients. It has an adjuvant arm where patients are randomized to either Nivo-Cabo or Nivo plus an oral placebo, or it has a metastatic cohort if you find that your patient is actually unresectable or tried to go to resection but ended up with an R2, then it's a single arm study of Nivo-Cabo alone. I should be up here advancing the slides, I suspect. So this has been the enrollment so far as of this past Tuesday. It's getting more, it's getting opened at more sites across the US. So, this is a good enrollment so far. Now, there have been some grade 3 adverse events. The cabozantinib can be a toxic drug with regards to blood pressure, wound healing for the patients who are in the resectable cohort. And so what they've seen here is they've seen these side effects here: proteinuria, anorexia, a couple of cases of hypertension, a couple of cases of ALT elevation, myalgias, wound infection. I think even a diarrhea was reported. So as a result of some study stopping rules that they built in for safety, if a 40% possible, probable, or definitely related grade 3 or higher adverse event was reported in the first 10 patients, or higher than 40% rate after the first 10 patients, the study needed to pause. And we actually got an enrollment hold notification this past Tuesday that the toxicity threshold had been met for this study. And it was based on the ones you saw on the previous slide. So what is actually happening is the study chair is looking a little closer at the timing of those, and were they transient or were they difficult to resolve? An amendment has gone to CTAP or will go to CTAP, sort of redefining these DLTs or toxicities and being a little more liberal in allowing. It makes me realize, it is important when we assign the attribution of these side effects, whether we think it's possibly, probably, or definitely related. Anorexia, that's difficult to say. It could be related to their cancer. Comorbidities, concomitant medication, but certainly could be also from Nivo-Cabo in combination. So I think we have to be careful when we're assigning these, especially as it relates to potentially holding a trial. But these all seem very appropriate, so it's good that the investigators are looking at it. So that's really, I think, the last update for this study. Any questions with the mucosal trial? Okay. Thanks, everybody. Moving on, let me check my agenda here. We will do updates on our closed studies now. The first one is S1801. So S1801 will be presented next week at ESMO, I guess a little more than a week away at ESMO. We will be reporting the pathological response. And so we will see that now with single agent data and be able to kind of talk through that. So pathological response. And then we also have some translational medicine work going for what else to do with the tumor and blood, looking for biomarkers for response, recurrence, et cetera. Those translational medicine objectives will be sort of refined and streamlined and resubmitted to CTAP. All right, the next study is S1512. Carrie, if you have any verbal updates you want to give from here, wherever you like. Yeah.
It's short. I'll just do it from
Sure.
here. We're currently working on our pathological review. We've gotten through the vast majority of it. Some of the final stages there. Translational work is all underway. And hopefully we'll have a publication for people to review shortly.
Great. Congratulations on that one. So S1607 and S1616, CWEN is not here in person today. But she provided me updates on 1607. They are 1607 and 1616 both are really in the thick of their translational medicine work right now. 1607 is reviewing the last batch of slides. This was TVEC plus PD-1. And they are reviewing the last batch of slides. They think they will be stained and analyzed in the next month. And that paper will probably be a combination of the clinical results and translational medicine findings in one paper. 1616 as well. I think we've heard at the last few meetings, the last open meetings, that they're doing a flavor of multiomics work on that study. And that is also underway, currently doing the translational medicine work. And then the last study is S1404. So S1404 had its quality of life publication in February, and it is undergoing some translational medicine approvals with CTEP so that we can study those tumor tissues and blood samples, also looking for predictive biomarkers for recurrence, et cetera. We did a pilot project with Natera that we will round out here shortly. And then we've also got Katie Tsai's fertility project that is being part of the translational medicine protocol, I guess, that's going in front of CTEP. It doesn't include that one, but it will in the next version, where she's going to look for fertility markers in the female and male population exposed to checkpoint inhibitor in the adjuvant setting. So that's it for closed set studies. We've got time now to move on to, it's not David Lawson, it's a far younger version of David Lawson here joining us as the liaison from ECOG Akron and Emory, actually both. Mike Lowe is here to give us the updates from ECOG Akron.
Thanks, Epna. Much younger, far less wise than David Lawson. Am I controlling?
Yeah, I'm sorry.
We'll be brief with these first two studies. The first is 6194. This is Ahmad Tarhini's neoadjuvant study of Pembro with CMP-001, accruing well at 44 patients, and he hopes to finish accrual of this in the next 6 months.
CMP-001 is an intralesional?
It is, correct. That's exactly right. And if you have questions about these, please don't hesitate to ask. The second is Steve Hode's 6141, which is Nivo Ipi GM-CSF versus Nivo Ipi. Also enrolling well, 440 patients with an accrual goal of 600. He had no additional updates to add, but does encourage patients in the frontline setting who have not seen previous systemic therapy, PD-1 or ipilimumab, to consider for this study. Jeff Gibney's 6192, I would love some feedback from the committee on this study. This is his phase 2 biomarker-driven early discontinuation of PD-1 therapy in patients with advanced melanoma, affectionately known as PET stop. This has struggled to enroll patients mainly because of the timing of the way that the study is designed. So I'm going to run through the protocol design and then hopefully get some feedback from the SWOG Melanoma Committee about potential amendments that would increase the likelihood that patients can be put onto this clinical trial. So his hypothesis is that advanced melanoma patients with disease control by CT scan for 1 year can safely discontinue based on a negative PET scan. This reduces late adverse events, reduces the cost of care and burden on the system and the patient. It improves the patient experience because they stop their therapy sooner. Will help us identify patients at risk for future disease progression. And we could potentially expand this beyond melanoma to other tumor types. This is the schema. So patients pre-register, undergo PET scan, undergo biopsy if the PET scan is positive, and then they register. They're randomized, if they have a negative PET scan, they discontinue therapy. If they have a positive PET scan and their biopsy is negative, they discontinue therapy. If they have a PET scan and a positive biopsy, then they continue therapy with repeat imaging every 12 weeks. The key eligibility here are unresectable 3 or 4 melanoma patients treated with any anti-PD-1 based therapy. So this can include Nivo-Rela. They must have disease control maintained through their first year of treatment. They must not have had any prohibitive toxicities to immunotherapy. And their pre-treatment PET scan in place of a diagnostic CT is allowed if it can adequately assess the target or non-target lesions per the investigator's discretion. This was designed with an event-free survival primary endpoint that allows discontinuation of therapy in Arm A. So those are patients with a negative PET scan or a positive PET scan, but a negative biopsy. Then this is defined as recurrence, progression, or melanoma-specific death. The secondary exploratory endpoints are listed with a sample size of 150 patients, again, only of which 32 have been enrolled. And this target of greater or equal to 90% of patients in Arm A will be event-free at that 12-month point. So the issue with accrual is really based on the ability to capture these patients at that 12-month visit. It is difficult to assess who is disease-free at the 12 months and remember that they're disease-free at 12 months and have a negative PET scan and therefore are eligible with a relatively narrow window of 2 weeks at that follow-up visit at 52 weeks. So these are a couple of options that Jeff is batting around to potentially increase the likelihood that a patient would be captured if eligible for this trial. The first is to allow enrollment at day 0. So not screened at day 0 and then enrolled at week 52, but actually enrolled at day 0 so that they're actually on the ECOG or SWOG roster from day 1. If they progress, if they have toxicity and come off therapy, they of course become a screen fail.
Is that from day 0 or start of maintenance PD-1?
It is start of initiation of any therapy in the metastatic setting.
Okay.
So if it's Ipi-Nivo, it would be initiation of that combination, not.
You are going to have 55%, toxicity rate. So you are going to have a lot of people that then are not eligible for your actual randomization or so. Yeah.
It's a huge lift and there will be a ton of screen fails and we have to, as a group, accept that that's going to happen in hopes of getting patients that come through and are actually screened appropriately. So yes, that's the downside to doing that exact aspect of it. It's a huge lift for coordinators. It's a huge lift for the data managers.
Would it be easier for investigators to remember that you're starting treatment, enroll them then? Or would it be easier for you to remember when they're initiating maintenance therapy that, hey, they might be on this maintenance for a while. Let me see if I put them on this PET stop trial then. I mean, it's a question, I guess, for anybody in the audience who considers this treatment.
And what's the time difference between initiation of therapy and initiation of maintenance?
So with Nivo-Ipi, it's by week 12 or
by
so.
Week 12. So you say 40 weeks.
Yeah.
So it's still 40 weeks out though.
Week 12.
Into therapy.
Right.
With the assessment at week 52.
Not month 12, but week 12. So like 3 months into therapy. Right. Oh, okay.
Right.
Yeah. So, and with Nivo-Rela, there is no maintenance PD-1. They're on it from the beginning, so they could jump on that from the beginning. It's those Nivo-Ipi patients. I think people won't they're not remembering at the 12-month mark. That's clear.
That's correct.
And you wonder, are they going to remember this at initiation of therapy, worried that if toxicity happens, it's so much data that they have to put in just to have an inevaluable patient. Would it be easier to know your patient got into maintenance, got through the toxicity, and is likely to, if this lasts, be?
That is a great way to capture the patients that would go on to PD-1 monotherapy maintenance. Yes, that's it. For the PD-1 monotherapy only patients or the Nivo-Rela patients, we would be day 0. That's exactly right. That's a great suggestion that I'll bring back to Jeff.
Yeah, we flag all our patients when we start. So when we get to that window, we look. So they're all flagged, it's documented, and with these flags. The challenge we run into is one is getting the PET scans covered. And then the other is the time window, because getting the PET scans covered, falling within that time window and get everything done within that time window. We lost 5 people last month. Just because of that time window. Yeah. So I think broadening that time window is going to help us tremendously.
Right. Yeah. So great point. And I think that's a really, really important consideration, that you then only have 2 weeks to get everything done. Yeah. So a couple of other ideas. They can schedule all of this earlier on in the process so that we avoid this issue of identifying the patient as a responder with a negative PET scan or a negative biopsy, because we've already planned all of these interventions prior to them reaching that point, as opposed to identifying them and then having this very narrow window to get all of that done. And so that's suggestion number 2, that we can actually schedule things, say, halfway through their treatment in anticipation, because they've already registered in step 0, that we could sign them up for all the things that they're going to need at this week 52 assessment, so that they can be done in preparation to then go on to registration. Comment on that, Ashley?
Just thinking that number 1 makes sense to me for what you said. And my thought is there anything that could be done with the screen fail patients that would make the data that Sapna's, specifically mentioning that gets entered otherwise somehow usable, evaluable, where that lift makes sense? I don't know what that question is that would be answered from those screen fail patients, but if there's something that could be studied from that to make that worth it, maybe something else for him to consider. But I'm with you. It seems like it's not just 1, 2, or 3, but it's probably 1 and either 2 or 3.
Great point. Thoughts on using screen fail data for something meaningful?
Yeah, we should. It depends on what gets entered.
Right.
I mean, we know when people are ineligible in the database, the quality of the data that gets entered sort of around that is pretty suboptimal, but of course it should be. Why should a site invest a lot of ATP in that?
Right.
But it could be, something to think about.
So then the last suggestion would just be simply widen the window of opportunity to find these patients when they're identified at that week 52 visit, and expand it to week 4 to 4 weeks instead of 2. This does provide or automatically incorporate some variability in the timing of this, but presumably if they've not yet progressed at month 11, they probably won't have progressed at week or month 13.
Mm-hmm.
So that probably that larger window is less relevant when they've made it to a 12-month period without progression. And then the other suggestion that we discussed internally was some pharmacy queue, that's actually that there is a way when the patient starts therapy that the pharmacist is alerted to alert the study team, because they're the ones that are regulating distribution of drug. And I don't know of a way to incorporate that into our electronic medical record, but if others have experience with pharmacy prompts, we'd be interested in hearing about them so that we could incorporate them into the process.
Did you show us accrual already?
Yeah, 32 out of 150.
And 32 over what period of time? A couple years? 3
Yes,
years?
at least 2.5, but probably pushing 3, and CTEP's knocking on the door.
Oh, that's what I was going to ask.
Yeah.
Are you getting them?
Very much so. And that's why Jeff is, I think we all think that there's validity to this trial. The cooperative group is probably the only space that can pull off a trial like this. And it's up and running, and it's difficult to actually pull off. So we're desperate to think of ways that we could maximize enrollment.
And there's no way to redo the statistics to lower the sample size.
At this point, no, because I think that we all want that 90% to be the real number. I mean, the false negatives here, I think, would be the shame of the trial if we lowered our standard and said, is 80% sufficient? Is that really answering the question? I think we want to be confident that the patients that are coming off therapy can actually come off therapy.
How many of the fails are due to PET scans not getting covered?
That is a question I don't know the answer to, but I'm happy to bring it back to Jeff.
Yeah, if that's a reasonable amount, then maybe he can look into ECOG for funding. Maybe there's some way to get
with the
funding.
imaging subcommittee, perhaps.
Yeah.
It's a great question.
Yeah. But if it's not a high number, if it's
Right.
just this operational challenge, then it's something else.
Wonderful. Thank you all for your suggestions
Okay.
and your time.
Thank you. And then we will close with a word from our patient advocate, if you would like, Sam.
So I promise to be brief because it's before you get to the door and start your weekend. I know everybody's very busy. So I'm not actually not just closing up today, but also I think also SWOG for the week. And so I was trying to figure out a way to sort of share with you why the work that you're doing is so important. So many of you know, my sister was 26 when she passed away from melanoma. And it's going to be 20 years ago this Thanksgiving. And when she was diagnosed in February of 2003, there was only one treatment option that had been approved in stage 4 melanoma. And for those of you who knew my mother, who was my sister's caregiver, she was a very savvy person. And so you could imagine what she did and what she went through to find treatments, anything to save my sister and, or even at least give her a quality of life. And there was really nothing, literally, really nothing. There was stuff out there, but it was also incredibly hard to find. And so she, started this foundation, Aim at Melanoma, to change all of that. Now, I'm not suggesting she did it all by herself, actually just the opposite. But she would go to ASCO, and I'm sure some of you had been to ASCO at the time, and it was a big room that was incredibly empty, and there were trial results that were incredibly depressing to listen to. And that happened for many years. And it's really only been the last few years that things have changed. And so I want to press upon you how important the work that everyone, not just in melanoma, is doing here at SWOG, but in general. It is incredibly excruciatingly painful. And let's be honest. It's, trying to come up with concepts that are going to work. Trying to get through the IRBs, CTEP, and all of these other things, accruing patients, retaining patients. But if you look what's happened even in just the last few years, how far we have come from 20 years ago and how important all of that work is, and the feedback that we give each other, the importance of including patient voice in all of these things, and how much that can change the lives of patients and their families. And so I press upon you to continue the work you're doing despite the long hours, the difficulties that you have to overcome. It makes a huge difference in these patients' lives. So thank you.
Thank you, Sam. What a great way to end our SWOG fall meeting here. Thank you, everybody. Thank you to those online who joined on your Saturday morning. Take care. See you in Seattle.